hypertension, high blood pressure. There's two kinds of high blood pressure in pregnant women. One is they come into the pregnancy already with high blood pressure. That's called chronic hypertension, right? Some of you during clinical, we've had patients who came in already with chronic hypertension. Okay, that means that, so right here, they had these risks going into pregnancy. So apart from that, so if they already have chronic hypertension, then they're going to be at risk all, and we'll talk about that. Or if they're very young or very old, as far as OB is concerned, so if they're younger than 19 or greater than 40 years old, they're at higher risk for hypertensive disease. Preeclampsia, what does that mean? Preeclampsia. First, not pregnancy, delivery, right? Para is delivery, Gravida is first pregnancy, right? Gravida first pregnancy, para first delivery. If they're morbidly obese, so morbid obesity is a higher level of obesity than just obesity. So morbidly obese is if their BMI is greater than 35. If they have chronic kidney disease, CKD, chronic kidney disease, they're at high risk for hypertension. Again, if they already have chronic hypertension going into pregnancy, then they're at risk for preeclampsia. If they have a history of preeclampsia, but I think there's a test question at some point about this that I've seen. If let's say they have a sibling or their mom had preeclampsia during pregnancy, they could also be at risk for having preeclampsia. And same with diabetes, unfortunately, gestational diabetes. Or if they have diabetes, FDM, or if they have RA, rheumatoid arthritis, or SLE, systemic lupus erythematosus, So those are autoimmune disease. And these two are autoimmune diseases. So if they have any of that, it increases their risk. So if they didn't have chronic hypertension, which is again one kind, the other kind is gestational hypertension, or otherwise known as PIH, pregnancy-induced hypertension. Okay, so PIH, pregnancy-induced hypertension, or GH, gestational hypertension, it's talking about the same thing. Okay. So how do we define gestational hypertension? If mom's blood pressure beginning at the 20th week is high, how high? Greater than 140/90 times at least 2 readings. Okay, that is 46 hours apart. Then they are considered having gestational hypertension. Okay. And how do we know that this is gestational and not chronic hypertension? Because when they deliver the baby, their blood pressure normalizes. Okay, and not immediately, because they can still get preeclampsia at postpartum, but 12 weeks later, when they're all recovered from the delivery, then their blood pressure normalizes. Okay, so then that's just gestational. So as far as just gestational hypertension, usually diet and exercise is what they'll be taught to do, right? Just kind of watching their intakes, but really nothing else. However, if it gets worse, then it could become preeclampsia. Okay, so it could be just gestational hypertension, but then when it becomes preeclampsia, and follow the red here, so it's just the blood pressure that's higher than 140/90 for preeclampsia. Okay, don't look at the peak yet. But this is what happens in preeclampsia. The blood pressure becomes so high that it's causing spasm of the blood vessels. And so when there's spasm of the blood vessels, then that leads to decreased perfusion. Right? So you follow the purple for now. So there's decreased perfusion. So what is the definition of perfusion? What is perfusion? Flow of blood, what kind of blood? Oxygenated blood, right? To organs and tissues, right? So when there's decreased perfusion, you're saying there's decreased flow of oxygenated blood to organs and tissues. So, let's start with the brain. So that's called ischemia, right? When there's decreased perfusion, there's ischemia, lack of blood flow of oxygenated blood. When that happens to the brain, in a blood pressure greater than 140/90 only right now, then the patient will manifest with transient headaches. Okay, so your mom, you would ask, have you been having any headaches? And so, yeah, I've been having headaches, but then it kind of goes away after a while. Or they may have episodes of irritability. Okay, they're more irritable. Why do we become irritable? When there's ischemia, your frontal lobe is all personality. So when you're, even a normal person, when you lack sleep, you don't get enough rest, you're dehydrated, you get irritable, right? You don't have enough glucose, you're irritable because the frontal part of your brain is not getting enough blood flow. Okay, so that's that's the mild preeclampsia. Okay, so the red ones are mild preeclampsia. Okay. And then another thing that may happen to the mom is that if there's decreased perfusion to her bone marrow, so she might go into compensatory polycythemia. What is polycythemia? Poly means many, cyto means cell, emia means blood. Many blood cells, in this case, many red blood cells. Okay, so it increases the red blood cells. So the bone marrow is like, hey, you don't have enough perfusion going on to the organs, so maybe you need more red blood cells. So then the bone marrow produces more red blood cells to compensate. Okay, so then what happens is now the blood has more RBC. Okay, so that's for mild preeclampsia. Okay, and then as it gets more severe, then more problems happen. But let me go through the kidneys first before we go to that. So in the kidneys, when there's decreased blood flow, so a couple of things happen. Again, there's decreased perfusion to the nephron, and so the glomerular filtration is going to be decreased, right? GFR, glomerular filtration rate, that's going to be decreased. There's also going to be inflammation in the glomeruli. Where's the glomeruli? Glomerulus is singular, glomeruli is plural. Where is that at? In the nephron, right? Each nephron has if you, anyone visual, it's like that ball-like thing, right? That's a glomerulus, right? Each nephron has that. That's where filtration happens, right? In the loops, that's where they transfer, they shift electrolytes and fluids. But in that wall is where filtration happens. So that becomes inflamed because whenever there's ischemia, inflammatory mediators are going to get activated. So because that gets inflamed, the walls of it become more permeable, right? There's an increase in capillary permeability. When that happens, albumin that is supposed to be kept inside the blood vessel wall comes out because the walls are now bigger. There's more holes, right? What is the function of albumin? What is albumin? It's a protein. What is the function of albumin? I know you guys have taken fluids and electrolytes, maybe in physiology or something. Repair tissues. What else? What about in the blood? What kind of action, what kind of force does it have in the blood? Albumin. Push or pull? Yeah, pull, osmotic pressure, right? So when there's albumin in the blood, it's maintaining the proper pressure inside the blood vessel wall. It's pulling the water from the tissue to the blood and keeping it there. Okay. Now, when albumin escapes the blood vessel, what happens? Wherever albumin goes, water follows. So then what happens? The albumin is no longer in the inside the blood vessel wall, right? So your serum albumin goes down, right? Where is it at? You're peeing it out. The mom's peeing it out. So it's a protein. So then the mom's gonna have proteinuria. In mild preeclampsia, that's a protein of 1+. In severe preeclampsia, that's about a 3+ protein. You might see less questions that, talk about that. Okay. So because mom is peeing it out and it's getting decrease in the blood, so now there's decreased oncotic pressure, right, in the blood vessel. So where's the fluid gonna stay? In the tissues, causing edema. So this is why in preeclampsia, mom gets edematous. Okay, it's not just what's called dependent edema. Dependent edema is when they're standing, their legs swell because of gravity, but then when they put it up, it gets better. This is different because it's not caused by that. It's caused by the lack of albumin, right? So again, in mild preeclampsia, it may be just some edema, maybe a slight swelling, and then it becomes worse in severe preeclampsia. So what do we ask the patient? Or usually what they'll say is, my fingers look like sausages, or my rings don't fit anymore, or my shoes are really tight, right? So those are some signs of edema. In severe preeclampsia, that's defined as blood pressure that is greater than 160/110. And basically there's just a greater decrease in perfusion, right? So then what happens to the brain? The headaches become more severe because there's greater ischemia. The mom's vision becomes more blurred. Why? Because now also the occiput, the occipital part of the brain where the optic chiasm is affected. Okay, so and the blood pressure and the retina is also increased. So they will get blurred vision, headaches, and hyperactive DTR. So what is a DTR? Deep tendon reflexes. When you say hyperactive, what are the grades of your DTR? And these are things that when you go to the hospital, you will document. Okay, you need to do your DTRs, you need to document what the number is. What is normal DTR? 2 to 3 is normal, right? Where do we check the DTR? So your patellar, right? Patellar reflex here, radial, brachioradial. So these are deep tendon reflexes. So you're actually checking the tendons, right? So radial, brachioradial, patellar, Achilles heel. Okay, you will check them bilaterally. If they have preeclampsia, they may become hyperactive if it's severe preeclampsia. Okay, and so they might even have an ankle clonus. So what is clonus? A spasm. So their ankle might be going like this, spasming. Okay, because of too much irritability of the brain. So these are signs of severe preeclampsia. Okay. When it becomes eclampsia, I can't recall if ATI talks about eclampsia or just severe preeclampsia. I think it's just severe preeclampsia. But basically, when it gets really bad, in the severe preeclampsia, it can get so bad that the mom can get seizures. And then coma. Okay. So pay attention to, again, if it's pink, that's severe. If it's red, that's kind of mild preeclampsia, sorry. Because there might be ATI questions that will ask about severe preeclampsia versus mild preeclampsia. Okay. So pay attention to the protein. How much protein is it with severe? How much protein with mild?
How do we know that GFR is decreasing in severe preeclampsia? We will look at our serum creatinine. Normal serum creatinine, depending on the textbook, might be 0.8 to maybe 1 or 1.2. So as that's increasing, because it's being trapped in the blood, right? The kidney can clear it out. Then you're not getting the urine, so the mom's gonna have oliguria as well. What does that mean? In a preeclamptic patient, part of your nursing interventions is you monitoring urine output. Okay, so you monitor urine output, you monitor vital signs, you monitor DTR. Those are the main things in preeclampsia. Okay. In the liver, actually, hold on. Let's see this. So I'll talk a little bit about the liver, but we'll come back to this when we talk about bleeding issues. Let me just also say, we'll talk about placenta abruptia later on, but I want you to also associate preeclampsia to placenta abrupta. Placenta abrupta is a condition wherein the mom's placenta detaches from the uterine wall. And so that's going to cause bleeding. And we know that the placenta is what provides nutrition, right? So if it starts detaching, then the baby doesn't get any blood and then any nutrition, the baby can die. Okay, so that's a medical emergency. And how that happens is sometimes this is severe preeclampsia, the blood vessels will start rupturing because the pressure is so high. So then the placenta begins to disconnect, detach from the uterus. Okay, and we'll come back to that next week. So in severe preeclampsia, part of it is there's also decreased there's decreased blood flow to the liver. And so here's some things that happen. In the liver, again, we're gonna there's gonna be an increase in the total bilirubin, so we're gonna have a lab for you if the liver is affected, right? So basically what this is saying is if you have a preeclamptic mom, you're checking their lab, right? So what lab are we checking? We're checking their AST, their liver function test, their AST, their ALT, and their total bilirubin. Okay. As far as the liver is concerned, you're checking to see do they have any yellow jaundice, right? If the bilirubin is high because the liver is not functioning and the bilirubin is backing up into the bloodstream, you might see a carrot sclera. A carrot sclera is yellow eyes. Okay. And then as it goes into the skin, they're going to have drier up skin, they're going to have pruritus. What is pruritus again? I mentioned earlier, it's itching in the skin. And we're going to see bilirubin in the urine because it's in the bloodstream. The kidney is going to want to speed it up, so then it's going to feed it out. So you're seeing if liver is involved, you're seeing bilirubinuria, and you might be seeing a high bilirubin, total bilirubin. That's for decreased liver function. This is for liver inflammation. Okay. When the liver is inflamed, we're looking at the ALT or the AST. And it will be elevated. Okay, so when you guys, those of you who are going to clinical Thursday, Friday, I want you to kind of look at those, okay? Especially your preeclamptic moms. So another thing that happens as the liver gets ischemic, it can go into a hemorrhagic necrosis, so it could bleed out. So as the liver is kind of bleeding out, getting swollen, so your mom may have these complaints. They might have some epigastric pain or right upper quarter pain, because that's where the liver is at, right? And nausea and vomiting. And the danger there is if the liver becomes so inflamed, it could rupture. Okay, and of course, more bleeding will happen. Okay. When we talk about bleeding, I'll talk about these other ones here as well, but so they're not gonna be in your test yet. Your test will be basically just preeclampsia, but when we talk about bleeding, we'll talk about these. So let's talk about interventions. And then we're gonna go down for the exam. So if the mom is hypertensive only, right? Gestational hypertension, no signs of preeclampsia, or even with signs of preeclampsia, but we're dealing with the blood pressure, these are the medications that they might be given.
So methodopa is a good choice for pregnancy. That is actually also a drug for Parkinson's. That's a dopamine agonist, but it works well in pregnancy as an antihypertensive, and it's safe in pregnancy. Okay, nifedipine, what class is that? Calcium channel blocker, CCTB. So that's another good choice. Usually if this mom is in the hospital setting, and the blood pressure is really high, they will get labetalol or hydralazine. Okay, labetalol is what class? Beta blocker. So what will you watch out for? So check the heart rate, right? Make sure that it's not lower than 60. Hydralazine, what class is that? Hydralazine is also usually given for a high, really high blood pressure. This is a direct acting vasodilator. Direct acting vasodilator, hydralazine. So that's pretty strong. Okay, so usually nifedipine. Now here's the thing about nifedipine. It's a calcium channel blocker, right? What happens? What is calcium for? Contraction, right? Must tone, right? So if you're blocking calcium, that means that you are blocking tone. So in pregnancy, who is it good for you then? When do you want to block tone? Contraction. So if the mom is having premature contraction, right? So CCB works both ways. You're using it to relax the uterus so it doesn't contract, right? At the same time that you're using it to block the calcium in the blood vessels, relax the blood vessel. That way they relax and they lower the blood pressure. Does that make sense so far? Who are they contraindicated for? Who will not get CCB in pregnancy? When? Yeah, when you're trying to induce pregnancy, right? Because it's counterintuitive, right? If you want to have contractions, well, you give them a medication that blocks contractions, right? So what does that mean? If this mom is already in labor, right, and their blood pressure is high, the nifedipine is not a drug of choice because it contradicts the action, right? So a medication that likely will be given is magnesium. Okay, magnesium sulfate. So magnesium sulfate is not just for seizure. Okay, magnesium sulfate as an IV medication is a CNS depressant. So I want you to remember the action because all of the things that you're going to check is because of that mechanism of action of that class. So magnesium sulfate at a high dose IV is a CNS depressant. So what are the effects that we want? Because it's a CNS depressant. It's going to lower the blood pressure, it's going to relax the blood pressure. If the mom has fever, it's going to calm the brain down, right? Because it's the CNS. That's why it's an anti-epileptic. But because it's a CNS depressant, there might be symptoms that may be a sign of overdose. So whenever you hear mag sulfate, again, I want you to think DTRs. We're going to check DTRs first as baseline. There's a lot of test questions about preeclampsia, okay, and mag.
So when you hear mag sulfate, you hear preeclampsia, you're checking DTRs as a baseline. And you're checking for signs of magnesium toxicity. Okay, how do we know that magnesium is too much? Well, first of all, they're gonna have blood draw, right? Like one of the patients we had Monday, they were checking mag. I don't know if any of you guys saw that. They were checking mag because the mom was getting mag infusion for preeclampsia. So apart from the lab, you guys are monitoring vital signs. Okay, so how do we monitor vital signs? So if this is an initial treatment, they're gonna start with monitoring it every 5 minutes, then every 15 minutes, then every hour. Okay, the neuro is checked every hour while they're getting a magnesium infusion. Okay, again, because this is a CNS depressant. So what do you want? What do you not want to see? You don't want to see lethargy, right? You don't want to see areflexia. What is areflexia? No more reflexes. How do you know that? Because you check the DTR, right? So what's normal DTRs? 2 to 3. So if they were hyperactive with the preeclampsia, they may be at 4 or 3 plus, right? So now if they're at 1, then you know that has decreased. So that's a problem, right? Urine output, because they might have urinary retention because of the CNS depression. So you're checking urinary output. Okay. What is considered decrease? An output that is less than 30 mLs per hour for at least 2 consecutive hours. So if you're given, let's say in a test question, you're given an output for a whole shift, let's say from 7 to 3, this is the patient's output. So what you would need to do is divide that by 8 and see what the hourly output is and see if that hourly output meets that 30 mLs or more. If it's less than 30 mLs, that's decreased urinary output. Okay. So those are the main things that you would check for. Now, what if you see those things? Then you're gonna DC the IV. You're gonna anticipate that there's already an order for an antidote, which is calcium gluconate. Okay, so you're gonna give calcium gluconate, and if this mom is very lethargic, maybe with decreased respiratory rate, you might need to call rapid response team, RRT. If it's so bad that they now have a VFib or some kind of dysrhythmia and they have a pulse, obviously they're going to call for it. But we want to prevent these things from happening by the monitoring regularly, right? That way they can adjust the magnesium dose so that the mom doesn't go into magnesium compensation. Okay, so if you don't learn anything else from today's lecture, remember preeclampsia, DTRs, and magnesium, and how they all kind of affect each other. Okay.